Medtronic technologies impacted more than 72 million people in the last year, equating to 2 people every second. Harnessing the power of technology to take healthcare further, each technology has unique benefits designed to serve patients. The goal of this program is to get closer to the patient and delve into the challenges and impact of each technology in practice. This is the Medtronic MedEd learning experience. The SonarMed Airway monitoring system should not be used as the sole basis for diagnosis or therapy and is intended only as an adjunct in patient assessment. Medtronic's medical education programs are offered to provide attendees education on FDA-cleared indications and use of our products when applicable. The contents and conclusions of the following program are solely those of the speakers unless otherwise cited. The speakers are responsible for all content and any necessary permissions. The speakers received funding from Covidian LP, a Medtronic company, for this speaking engagement. For this segment of the series, a discussion on unplanned extubation in the NICU. What is the cost of unplanned extubation? To help answer this question is John Sanford, Respiratory Therapist Clinical Educator at Children's of Illinois.
It's a tough decision. We don't really have too much of a priority to the patients. If there's a monitor that's available, it goes on any intubated patient that's on the unit. But we will at times try to push the monitors towards, say, a patient that's already had a UE, so we don't want any repeat offenders, or a patient that has a tenuous airway. We really are watching a little bit closer and something that we're concerned about. Sometimes even some of the bigger kids that we notice that have real strong necks and purposeful movements with their hands, something that has worried us or caught our attention, we may try to steer the monitor towards that patient in particular. We usually use positional aids. So we have some bean bags that we'll kind of use, or just a kind of a cloth diaper, rolled diaper, or a blanket or something. So it's pretty much exactly the way we did it before. We didn't really have to, change the way we supported that ET tube. It's the weight hasn't been a factor. The length adds a little bit of cumbersomeness to it, but we quickly got over that. It wasn't a deal breaker for us at all. Yeah, it took a little bit of time for everyone to get used to it and to kind of understand what the monitor was trying to tell us. But it has a few different screens for us to kind of look at the metrics or the numbers that it's given us. So the alarms sometimes or early on were a little bit difficult just because we were setting them extremely tight because we really didn't have a baseline on where to put it. So once we got comfortable, we started widening those up a little bit, and then it kind of cut down on the nuisance alarms that we were getting. We were getting, a monitor that would just sit there and alarm, just because we've kept it. At first, we kept them really tight, but then as we got more comfortable with the machine and the device, we kind of were able to kind of pull those alarm limits out a little bit more and kind of not get the repeated alarms. Yeah, so our suctioning procedures have changed a little bit with the device. We use safe suction distance measurements for every baby that's intubated. So of course we've got to add a little bit more length to get down to the tip of the airway. So we do that calculation. We post it up for the nurses and it gets passed on a report for the RTs. And the device will tell you if there's a percent occlusion of the airway. So we tend, we would have a frequency that we would go in and assess our patients, see if they need intubated, or sorry, not intubated, but suctioned. And then a lot of times we would just suction during those cares. And then in between, if we notice that maybe the monitor is alarming and saying that there is a percent occlusion, and it was to the point where we can kind of see if our baby was desatting, maybe having a bradycardic component to it, we would go in and do an additional suctioning with that. But sometimes we may even pass on even suctioning, deep suctioning our patient, just because it wasn't necessary. A nice feature on the monitor is where you can actually listen to breath sounds without even putting a stethoscope on the baby's chest. So if we could turn that feature on and the breath sounds were clear, my heart rate and SATs were doing fine, everything else was stable, we may defer the invasive suctioning to another point in the cares when maybe we were getting cues that the patient actually needed it. The positioning of the patient in the isolette with the adapter, since it does add some distance or some length to the end of the ET tube, what we tended to do is we will adjust the baby as we turn. We'll do position turns with the ventilator circuit and the ET tube, but we'll set the baby just off of midline of the isolette. So if they're back, if they're laying on their side, we will actually move them just slightly over to the side to give us distance to actually still advance the catheter down the adapter and then down the airway a little bit easier. So that kind of change in positioning has really helped ease that process of suctioning while maintaining, that warm environment in the isolette. Instead of dropping the side of the isolette all the way down, we could still just work through the portholes just fine. I wouldn't be able to guess how many. I don't know how to answer that question about the nuisance alarms. But I mean, we do notice if a patient is alarming a lot, and we're constantly having to go in there and assess the patient, that maybe we can widen those alarms up if there is really if it's a non-issue. A lot of times we'll just we'll increase that distance a little bit if we're able to, or we'll just double check and make sure that the alarms are set appropriately, because there's been times where we didn't realize it, but maybe we've changed ET tubes, the patient changed out the adapter, but didn't adjust our alarms to it. So checking the alarms and the settings of the monitor tends to be more ingrained with the routine cares of the RT. So they will look at the monitor and make sure they're set appropriately. The alarms that we'll set for our patients, it kind of goes by ET tube size. So as the ET tube size gets a little bit bigger, we understand that with the anatomy, the airway is a little bit bigger, so that we can increase that alarm distance accordingly. Medtronic gives out some guidance of where to start with your alarms, and we've pretty much followed those.
Thank you for listening. This is the conclusion of the Unplanned Extubation in the NICU podcast series. Please tune into other series from Medtronic MedEd Learning Experience wherever you find your podcasts.